My name is Ashley. I am a labor and delivery nurse at Mercy Health, and I am going to be teaching your prenatal class. I have been with Mercy Health for about 13 years. I did postpartum for 3 years, and then I have been in labor and delivery for almost 10 years now. I have 5 kids of my own. My oldest is 11, and my little ones are 3-year-old twins. So I definitely can help you with the labor and delivery process with this whole class. So we'll go ahead and get started. At the end of the class, we will have frequently asked questions. So we'll go over all of that with you as well. So we will start. This is the gift of motherhood. Choosing healthcare for you and your baby. So a lot of you already have OBs that you have picked out for your delivery. You already know what hospital you are going to. So this just talks about the hospital setting and what you would like for your experience. There are tours that you can do on your hospital, but right now we are not doing tours, unfortunately. Things to consider when choosing a hospital. Does the facility offer birthing rooms? Our facility offers birthing rooms. So what that means is you will go to a labor and delivery room. We have 10 labor and delivery suites on our unit. One of those will be for you when you come in labor. You will labor in there, have your baby in there, and then about 2 hours after delivery is when we will move you to a postpartum room. The postpartum room is just on the other wing of the hospital, and that is where you will stay until you are discharged home with your baby. Other frequently asked questions. What is the hospital's policy of rooming in? So all of our babies room in with their moms. They are in the room for every procedure. So the doctors will come in every day and check on your baby, talk to you about what is going on. They will do the hearing test in there, the first bath in there. The only time they come out of the room is if they need to be monitored a little bit more closely, or if your baby is a boy and getting circumcised. How many people are allowed in the birthing rooms right now? Right now, we are allowing one person to be your visitor the whole time you are here. They will check in with you, they will get a wristband on, and then they will be the designated visitor for your whole stay at the hospital. What are the visiting hours? Unfortunately, our unit, we cannot tell you when you are going to deliver. We can't say, nope, after 11 o'clock, we can't have visitors. You could come in at midnight and have a baby. So we don't really restrict visiting hours with your significant other or whoever your person is that you are going to have for delivery. Siblings. Right now, we are not allowing siblings into the hospital, just one person. Breastfeeding educators, we do have lactation staff on our staff. They usually work during the day. All of the nurses have taken extra breastfeeding courses, and we are continuing education to make sure that we can help you troubleshoot if you're having issues with breastfeeding as well. Security features that we have at the hospital. So every hospital is different. A lot of the hospitals do have baby bands. So your baby will get one usually on the wrist and then usually on their ankle. And then mom will get a band, and whoever they choose for that significant other, they will get a band too. The band usually says mom's name, her medical record number, and then it will say babies, if baby's a boy or girl, and then also will have numbers on it to match. And we always check those numbers with you and your baby. If your baby's taken out of the room for a reason, we will check that to make sure that that is your baby when they are brought back in. Other security features we have on our badges, we actually have a purple hue around our badge. What that means is that we are able to take care of women and children. We also have, students that are around. Sometimes we have doctors that are around, and they may not have that purple hue. So if you ever feel uncomfortable, you just let your nurse know, put on your call light, and someone will come in and check and make sure everything's okay. The next security feature we have are HUGS tags. What those are, it's kind of like a little magnetic sensor that goes on baby's heel. That is put on usually right around the birth time, and then that does not get taken off until they are going home in the car seat discharged. That protects baby from getting outside of the unit, okay? So if that baby gets too close to the doors, or if you're changing a diaper and it gets loose, it will alarm at the nurse's station, and then a nurse will come in, make sure everything is okay. The other security feature we have are locked units. So every area that has women or has babies or kids in are locked units. So that means you cannot just go in through the door. You have to use a badge to get in or out, or there is a silver button that is on the wall. You will press that, and then that is how they will see that somebody is at the door on a camera at the nurse's station or at a reception desk. And then they will ask you who you are here to see, and then they will let you through the door. So to get in, you have to buzz in, and to get out, you have to buzz in. So those are kind of the security features that we have here. Birthing center, so a lot of you are coming to a hospital. There's birthing centers not really around this region, but if you do decide to go with a birthing center, these are some of the questions that you should be asking them. So does a center allow for low-risk births? Are they affiliated with a hospital or a doctor if you need an emergency? Will my insurance cover that? Selecting a healthcare provider for your baby. So a lot of people always are looking for a doctor for their baby. If you don't have one when you come to the hospital, there will be one assigned to you, and that doctor will be assigned to you throughout your visit. There are lots of pediatricians that round every day. There's a group of them. So you may not have that specific pediatrician that rounds on your baby, but if you don't pick a pediatrician out, that is the one that you can do your first follow-up visit after the hospital with, and then you can decide if you want them. If you are interested in a Mercy Health pediatrician, you can call 971 Doctor. We have many different doctor's offices through the region that you can find a doctor's office that's close to you. I always tell my families to network. Ask your friends and family who you like, who's really good, all that kind of stuff, because that will play a big role in if that's going to be the best provider for you. You can also set up interviews with them. So you can go to their office and ask them, questions, make sure that your personalities are going to match. You kind of have the same, views on what you want your baby to have. Right now, they may not be doing in-house interviews, so you may have to call and talk to them on the phone. But this is stuff that you can ask about office hours. Do they have weekend hours? Usually they don't have holiday hours. There is always a pediatrician on call if it's after hours that you can call. It may, again, not be your doctor that you have picked, but it may be somebody within that group that can help you out too and decide if your baby needs to be seen. Thinking ahead to childbirth. So a lot of this stuff that we are going to go through right now is stuff that you've been told probably through your whole pregnancy. A lot of people take this class after their 24 weeks. So this is just kind of some reiteration of stuff that you've probably already been seeing. So watching your diet, emotional health, oral health, physical activity, smoking, and alcohol during pregnancy. So watching your diet, eating a very well-balanced meal, taking your prenatal vitamins, making sure that you take your folic acid, especially in that first trimester, and then also making sure you have grains, milk, meat, and fruits and vegetables in your diet. So foods to avoid during pregnancy. There's some stuff that you should not be eating. So raw or undercooked meat, any unpasteurized milk, raw or undercooked eggs. You also want to stay away from pâtés or any cheese like feta, brie, or the blue veined cheese. You don't want to eat that when you're pregnant. Emotional health. So pregnancy is a time where it's an enormous change in your body. You have lots of hormones that are helping maintain your pregnancy. So you may cry at the drop of the hat. You may be more emotional, and that is completely normal. The best things for you to do is continue to exercise, eat a well-balanced meal, make sure that you are getting sleep and rest, and if you are having any issues, please discuss them with your healthcare provider because there are medications, if you do need them, that you can go on. Physical activity in pregnancy, that is really important. It actually can help you during labor. It improves your energy level. It'll improve your endurance. It's better circulation, less swelling. It helps you sleep better. And it also can improve some of the complications that you can get when you're pregnancy, diabetes, and preeclampsia. Smoking in pregnancy, we tell you obviously, please do not smoke. Please do not drink when you're pregnant. A lot of people who are smokers will tell you to kind of cut down. If you're smoking a pack a day, we want you to start cutting down to eventually getting to none. If you can try to quit cold turkey, that's great, but it's a lot harder for you to do that. So we tell you just to cut down so you're not smoking when you're pregnant. Making decisions about your care. So obviously you are watching this video. This is probably one of the best videos to watch because we kind of go through everything. We go through pregnancy, we go through labor and delivery, we talk about inductions, C-sections, aftercare, breastfeeding, and newborn. So this is a good kind of all-around video for you to watch. If you do have any questions, you can always ask your healthcare provider, but this is the stuff that we're gonna be kind of going through today. Other things that you will also learn during this class is pregnancy and labor. We will talk about how to not fight the contractions and to really try to relax your body. We'll also talk about available pain management options. We'll also talk about how you can support the labor person while they're in labor. So the BRAIN acronym, this is kind of what we use. It's kind of confusing, so I use an example with it that kind of makes it a little bit easier. So let's say you are in labor, you come in, you are 4 centimeters, you're really uncomfortable, we check you a little bit later, you're 5 centimeters, you want to get an epidural, we get you an epidural, you're nice and comfortable, and then your contractions kind of start petering out and you're not really changing. So we can ask, all right, your provider wants to break your water, okay? So that means we're gonna break your water. So what are the benefits for this? How will this help my labor? How will this help my baby, and how will this help me? Well, this can speed up the process because that water bag will be broken, so there's no cushion there. So the baby's head will be putting up pressure on the cervix opposed to that water bag. So that's a benefit. The risks, how will this affect my labor? How will this affect my baby? So that water bag will be broken, so that means that that barrier is gone, so it can increase the risk of infection. However, that does not mean you're gonna get an infection. There's people that can have their water broken for a long time that don't get infected. But we watch that. We make sure that you're not getting a fever, baby's looking good, all that kind of stuff. So risks for that, how will that affect me? How will it affect the baby? Alternatives, what are my other options? So can we wait a little bit? Can we change positions? Can we maybe start some Pitocin to get those contractions going more frequently? That's another alternative. So intuition, what does your gut say? Does your gut say, I think I want to do it, I want to get this over with, or, let's not do that yet, let's wait a little bit longer and maybe start some Pitocin and see if we can get those contractions a little bit stronger. Need time. So the need time is where you need to talk with your significant other or your support person about what you want to do for you. We are your nurses. We will advocate for you. Whatever your decision is, we will help you through that. So that's kind of the BRAIN acronym that kind of helps you guys know there are different options during your labor and delivery process. Circle of care. So educational support from your educator and then also the lactation staff can help you in this process and make this a little bit easier and more understandable. Knowledge is power. This is the role of the labor and delivery support person.
Comfort measures are important for the partner to know and understand. There are many that will aid in reducing pain perception, as in dancing with your partner, or through touching and massage, or breathing with her through contractions.
So that's some of the stuff that they can do. So you will learn emotional support, how to keep them informed, how to keep them progressing, reassurance, making sure, telling them, you're doing great, keep breathing through it, you're awesome, you're gonna get through this. Techniques taught in class, online programs, willingness to breathe, and staying relaxed is a big thing, especially for the support people, to kind of keep them going, keep them going, tell them that they're gonna be all right. Timing of contractions, so you can time contractions if you want, especially when you're at home. I know there's a lot of apps now, even from when I had my babies 3.5 years ago, that you can download an app on your phone and time your contractions so you kind of know how often you're having them. In the hospital, we put you on monitor so we can kind of know how often you are having contractions. So that's another thing the support person can do at home. Other things that they can help you with, pressure points and massage. That is something that some people want to be touched when they're in labor, you know, rub right here, hold my hand, and some people are like, don't touch me at all. I do not want you to touch me. Let me get through this contraction. Everybody is different with their labor and delivery process, so it's kind of up to you on how you are feeling at that time. Good things for pressure points and massage are right on your back, right here by your spine. If you put pressure with your fist here, and kind of roll up and down, that helps with that back pain. Also rubbing feet, that can help as well. So whatever is comfortable for you, there's lots of different things that you can try with that. Understanding comfort measures. So positioning is a big thing. You know, they're standing up here dancing. You can, you know, lean over the bed. You can squat on the bed. You can go in a recliner. You can go in, you know, lay on one side, you can lay on the other side. There's lots of different things that you can do for positioning as well. Bringing body pillows in, that is something that a lot of people really like. Assessment of relaxation needs, so making sure that you're relaxing and using breathing techniques is a very good thing to do. Crowd control, with now we only have one visitor, that should not be an issue as of now. If we do start going back to where we're having more visitors, then we would be able to do that as well. Updating family and friends. Your significant other can call them, let them know what's going on, kind of keep them informed if you're wanting your family to know. Communication is the big thing. It's a key in the cycle. So a lot of the partner's fears and concerns. Will she get through labor safely? Will I be a good parent? I'm afraid to see her in labor pain. Am I going to pass out with the needle or the delivery? Is she going to have more time for me once that baby's born? Those are a lot of the common fears with the support people. So that is that. You may have some of the following fears as yourself. Will our baby be healthy? Am I going to tolerate labor? I'm afraid of the pain. I don't know what it's going to feel like. I'm afraid of needles. Will my partner still find me attractive? So those are kind of the common fears and concerns with after delivery. Relaxation is the key in breaking that cycle for all the fears. So the fear and tension and pain. Knowledge is power. Positive attitude and understanding the importance of relaxation will help you in this process. It's kind of like a puzzle piece. So the fragmented pieces that leave you unsure of how they fit together, putting those all together can help you understand this process. And this just kind of says this again as well. Education and knowledge of the birth process will set up a positive response pattern and a positive experience. Basic relaxation and body awareness. So progressive relaxation. After learning body's awareness, progressive relaxation helps you to understand the feelings of tension. Touch relaxation is a great tool when you are working as a team, labor partner through touch relaxation. Pain of labor. So where does that pain of labor come from? There's many factors that can be from. So the thinning out of the cervix, how far the baby's head is in the birth canal, lactic acid that builds up in the uterus, the contractions puts pressure on the fallopian tubes, your vagina, your rectum, your ovaries, the size and position of the baby, stretching of the vagina and perineum, and then also personal beliefs and cultural beliefs. And this is some breathing techniques that we use.
During labor, use the breathing pattern that works best and feels most comfortable for you. Your support person can help you combine your breathing and relaxation with comfort measures. Here are 3 different types of breathing techniques that you can practice: slow breathing, light quick breathing, and pant blow breathing. Some women find that slow breathing works really well in early labor. Breathe in slowly and deeply. With each slow breath out, relax your shoulders, hands, and face. Some women find that light, quick breathing works well when contractions become stronger and last longer. At the beginning of the contraction, take a deep cleansing breath. Continue with slow breathing in and out. As the contraction becomes more intense, use shallow rhythmical breaths in and out. As each contraction eases, end with another deep cleansing breath. Pant blow can be helpful if you have the urge to push, but your cervix is not fully dilated. Take a deep breath in, breathe out with short pants, and then a longer breath, pant blow. Repeat until the contraction eases and end with a deep cleansing breath. Practice these breathing techniques along with other relaxation techniques so that you will be comfortable using them when you are in labor.
Okay, so that is the different breathing techniques that we do use. One of the biggest fears pregnant women have is dealing with that pain. So these breathing techniques are just one of the tools that you can actually use that will help you during labor. So rhythmic breathing patterns. So these are the patterns that you will use, and you will use the ones that are most comfortable for you. So the three different ones, the first one is the slow breathing. So you're gonna take a nice big deep breath in through your nose and blow out of your mouth. So count to 3 in through your nose. That one is very good to use. That is probably the one I use 90% of the time. That is good to use in between contractions, especially when you're pushing. It keeps you well oxygenated. You're not hyperventilating. It's also very good to use, especially in early to active labor. It really kind of keeps you relaxed, keeps you breathing, gives you oxygen, and gives baby oxygen. So that's probably the one I use 80 to 90% of the time. The light, quick breathing, this is one that you can use, and it's kind of it's kind of like the old stuff they taught you in Lamaze class. That one is okay to use. It's okay to use usually when you're a little bit more into transition stage, so like 8 to 9 centimeters. However, this one, if you use it too much, you can hyperventilate. So don't use that too much because you're not getting a nice big deep breath and filling out your lungs. So use it if you're having a contraction, and then use that slow, deep breathing in between. The next one is a very good one to use too. This is the pant blow one. So this one is very good to use, especially if you are feeling that urge to push and we're not ready to push yet. You're not fully dilated. So that is very good to use. It's a good distraction, and it's also a very good breathing technique during a contraction when you feel that urge to push. Whether you have an epidural and you feel that pressure or you don't have an epidural, these are the women that use this one probably the most, okay? So those are the 3 different breathing techniques. These are the questions we get a lot as well. So what to pack when you come here? So pillows, if you are gonna bring your own pillows, just don't bring white pillowcases so they don't accidentally get thrown in ours. A lot of people will bring bobby pillows. They will also bring body pillows just for they're a little bit more comfortable with their own things. Music, a lot of people have, Spotify. You can bring like Bluetooth speakers, stuff like that. If you want to bring food for the support person or for after you deliver, we can do that. We'll put a patient sticker on there and put it in our patient refrigerator so it's there for you. If it's going to be a long process, we're not really sure, you can bring a deck of cards, games. Some guys even bring their Xbox, which sometimes makes the patient a little upset, but they can bring that. Pair of socks, if you have a handheld massager, you can bring that as well. Cameras, so if you have a nice camera, a lot of people use their phones or iPads for that, but if you have a nice camera and you want to bring that, going home outfit for you and your baby, a change of clothes for your support person, toiletries. So we have, the maxi pads, the underwear. We do have soap and lotion and stuff like that here. But if you want your own soap, your own lotion, your own shampoo, then by any means bring that in for yourself. Reading materials, change for vending machines. Also, we do have clip-on fans that you can ask for, and we can get you one of those that you can take it home. It's a one-time use. Those are really awesome. Lip balm or chapstick's a good thing. And then bra and underwear. So bras, if you're gonna be breastfeeding, if you buy nursing bras or nursing tanks, just make sure they don't have any underwire in it. So that's kind of the stuff that everybody brings. When I had my kids, I brought a suitcase full of stuff and my husband thought I was moving in. So I tend to overpack, which is okay. So this is what we're gonna talk about now, discomforts of pregnancy. As you can see in this picture, this is what a normal body looks like. This is what a body looks like with a baby in it. It pushes everything up and puts pressure on everything as well. So that's why us women who are pregnant complain about having lots of different pregnancy discomforts. Some of the common ones are shortness of breath because that baby is pushing up on your diaphragm and on your lungs. Backache, you may get a backache. Nasal congestion, and then swelling in your hands and feet. Backache exercise, if you are having a very bad backache, this is just an exercise that you can use. Just kind of helps stretch out that lower back. Other discomfort, so sciatica, that is that shooting pain down your legs that kind of feels like a lightning bolt, or sometimes it's like a numbness that goes down. That is sometimes how that baby is laying in utero on that nerve. Good thing is that usually will go away. Sciatica is usually not a pain that is constant. It kind of comes and goes. It can be more when you're getting up or you're sitting down, but that should go away after pregnancy. Other discomfort, so round ligament pains. These ligaments are like rubber bands. These are what hold and anchor your uterus in place, and they're like, they stretch. So they stretch when that uterus is getting big. So if you all of a sudden don't have a belly and then you pop really big, you may have that round ligament pain. It's kind of like an achy, dull, almost like a muscle pain. Or people who have twins, a lot of times they will get that as well. The round ligament pain is usually worse too, as like you're getting ready to lay down in bed or you're getting ready to stand up. Usually once you're up and moving or you're laying down, it is okay and it feels better. Loose and achy joints. So the big thing with this is your pelvis. So you have cartilage in your pelvis, which I'm going to show you. So you have cartilage right here, okay? And this can stretch. It can stretch a few centimeters, and what that does, and it opens up your pelvis and your hips for that baby to eventually be able to come down into the birth canal, okay? So you may get that really, really, really low, like stabbing pain, hurting, and that's because that pelvis and that cartilage is stretching to make room for baby, okay? More discomforts that are common in pregnancy. So hemorrhoids, constipation, breast changes, skin changes, and being very tired or not being able to sleep. So skin changes, you see the line on that belly, that is linea nigra, and that is due to hormones and pigmentation. That will go away after baby is born. You may also see that your cheeks are getting a little bit red, and that is also from hormones as well, and that goes away after delivery too. So warning signs that need immediate attention. Preterm labor, vaginal bleeding, abdominal pain, high fever, decreased fetal movement, or any urinary discomfort, you should come in and get evaluated. So doing fetal movement, you need to track your baby's movement. So choose a time of day when the baby tends to be more active. You want to do this same time every day. You don't want to do, one time in the morning, one time in the afternoon, then you're doing night. You want to try to do it the same time every day. You want to sit quietly in a chair, couch, in your bed, somewhere, and really pay attention, okay? Get something nice and cold to drink. So get some water, juice, Sprite, whatever you want to get, and then really kind of feel and listen for baby movements. So swooshing around, kicking, hiccups, punches, that kind of stuff. You want to be able to feel 10 movements in 2 hours, okay? If you have 10 movements in 10 minutes, you're done. Your kick count is great, and that's awesome. If you do not have 10 movements in 2 hours, we want you to come get evaluated, okay? You should be doing this every day. Understanding labor and birth. So labor signs, Braxton Hicks contractions. Those are common during your pregnancy. Some people have them more than others. The one thing with Braxton Hicks contractions is they are usually painless. They are irregular, so they're not coming every 5 minutes. They kind of feel like your baby is balling up, almost feels like a basketball, or your belly feels really, really tight. Some women can actually start experiencing them at 3 to 4 months of pregnancy. Okay, so this is going to go over what the cervix does during labor. So effacement. This up here shows you what a cervix looks like when it is thick. okay? So 0%, that means you have a thick cervix. A thick cervix is usually about this from your second knuckle up. That is like a really thick cervix, okay? When you're about 50% effaced, when your cervix is 50% thinned out, it's usually up to that first knuckle on your finger, okay? Which means that that cervix is kind of melting and getting ready, okay? If you're 100% effaced, that is like a piece of paper. It's super, super thin. You sometimes can't even feel it, okay? And your cervix has to thin out and dilate for you to be able to have a baby. So dilation. If your cervix is not dilated, so you're 0% dilated, a lot of times it looks like a fist, almost kind of like a little hole here. You can't get your finger in that, okay? So that means you are not dilated, all right? 100%, which is 100% effaced, and then 10 centimeters dilated, okay? There is a chart we have here that shows kind of what it is. So 1 centimeter is, you can almost get one finger in. This is very subjective, okay? Your nurse or your doctor are the ones that are usually checking you. But this is what 10 centimeters kind of looks like, 1, 5, so this is what it is. And then there's also a chart on here. It's not the actual size, but it kind of gives you the guidance of how much you actually have to dilate, okay? So this is what the dilation chart looks like. So station. Station is something that's probably the hardest to kind of understand. But what the station is how far is that baby engaged in that pelvis, okay? So the baby, right here, you'll see -4. So you can't feel that baby up here. So that baby is up in Never Never Land. A lot of times if we can't feel that baby, we're having to do an ultrasound, okay, to make sure baby is still head down. If your baby is -3, that means that we can touch the baby's head when we check your cervix, but the baby's kind of palatable, so it's kind of still moving up. It's not fully engaged in your pelvis. -2 is where that baby's engaged. It's still high, but it's engaged in that pelvis and it's not moving up, okay? -1 is a little bit lower. 0 is where they're pretty low, okay? And they're right with that ischial spine. So you want your baby to be low as we are moving down into the pelvis, okay? When we are at +2, +3, that's when we go in to check you and that baby's head is right there on our finger, okay? And we're ready to start pushing. +4 is when we're crowning. So you'll see just that part of that baby's head even when you're not pushing, okay? So that is the station that we kind of talk about too. Bag of water. So the amniotic sac, that is the medical term. That is the amniotic fluid that is around your baby. It's also in the placenta's in there. The umbilical cord is attached, so the baby's belly button is attached to the placenta, and the placenta is housed in the uterus in a water bag, okay? The water bag acts as a cushion for the baby. It keeps the baby's environment nice and warm and stable. It keeps bacteria from coming in and out as well, okay? So this is kind of what the baby looks like in here, all right? So the umbilical cord is here, all right? And the baby is in the bag of water like this, okay? This part right here is what is attached to the uterus, okay? I tell everybody when you see it, it kind of almost looks like hamburger meat, but that is the part that is attached to the uterus, okay? The part that's attached to baby actually is very veiny, and that's where all the nutrients come in and go through the umbilical cord to the baby, okay? So that's the bag of water. Okay, am I really in labor? That's always a question. And unfortunately, you are the ones that can kind of tell that on your own as you start this process. It's very hard with your first one to know if you're in labor or not, but we're gonna give you kind of some pointers and some tips to kind of understand if you are in labor, okay? So, timing your contractions from the start of one to the start of the next, okay? True versus false labor, all right? So true labor, contractions begin and they are at regular intervals. They will increase in intensity. They will increase and get closer together. They will get more painful and your cervix will dilate. That is the key. Contractions that are close together consistently that make your cervix dilate is true labor, okay? False labor, so they occur at irregular intervals. They usually don't get more painful. Walking usually makes them better, and the cervix does not dilate, okay? So that's the big thing. So if you come in and you think you're in labor, let's say you come in, you're having contractions every 5 to 10 minutes, they're painful for you, we check you, you're 1 centimeter, okay? We'll maybe have you get up and walk for a little bit. We'll recheck you in an hour, and if you're still 1 centimeter and your contractions have spaced out, it's probably not true labor yet, okay? It could be early labor or some prodromal labor, so we'll probably send you home and let you rest, take a shower, and be in your own home till they kind of start kicking up again and getting really uncomfortable, okay? So this is a good thing to look at to continue with what's true labor and what is actually false labor. True labor, the cervix will dilate, your contractions will remain consistent, get more painful, get closer together. False labor, they're very irregular contractions, they get better with walking, and they tend to go away. And your cervix doesn't dilate. So timing of contractions. So frequency. The frequency is when they start from one contraction to the beginning of another. So you time the contraction from the start of one to the start of the next one, and that's how close together they are. The duration of a contraction is from the start of a contraction to the end of the contraction, and that's how long they are. A true contraction is 40 seconds or longer. So when should you go to the hospital? Listen to your body. I tell everybody, if you feel like something is not right, please come and get evaluated. We would much rather have you feel better, us feel better, and everything be okay and send you home than you be worrying at home and something be wrong, okay? So trust your gut, your intuition. If you think something's wrong, please come in and get evaluated. Reasons to go to the hospital. Your water breaks, you're having vaginal bleeding, you've done your kick counts and your baby's not moving much, any severe abdominal pain, contractions. So observe the following. Are they getting more intense? Are they getting closer together? Are you really having to stop and breathe through them? So what I tell patients is with contractions, if you start having contractions, we want them at least 5 minutes or less apart, okay, for at least a good hour or two, where you're not able to, kind of talk through them or go on the phone or, do activities. You want to actually, you're stopping, you're having to, don't talk to me. You don't want anybody talking to you. You want to really breathe through them. They're consistently like that. We want you to come in and get evaluated, okay? So ruptured of membranes. So your water can break on its own. Sometimes you might have to get your water broken. Every baby is different. Every person is different. My water broke with one of mine, and the other 4, I had to have my water broke. So it's different for everybody. If your water breaks at home, these are the questions that we ask you, okay? So what was the color of the fluid? Was it clear? Was it yellow? Was it brown? Was it bloody? Odor. Did it have any foul odor to it? Did it have a smell to it at all? The amount. How much was there? Did it soak your whole bed? You had to get up and change your sheets? Did you just have a little bit that came out and you're continuing to trickle a little bit? And then what time did it occur, okay? So those are the questions that we will ask you about if your water broke. If you were in the hospital, that's stuff that we look at as we call ourselves private investigators almost. We kind of know all this as your water breaks or you get your water broken, and we keep track of that for you. If you have to get your water broken, this is the amni hook that we have, okay? It's not a huge needle we put up and break your water. It's a plastic piece. It has just a little plastic hook on it, and your doctor is the one that will, or your midwife, will be the one that will break your water for you if it's time, okay? So they'll check your cervix, they'll break your water with this, and then let the water kind of come out, and we'll take a look and see what's going on, okay? So that is what the amni hook looks like. Pre-labor. So this is your body's telling you that it's probably getting time. You may get that nesting instinct where you're cleaning every day, you're prepping meals, you have your bags packed. You may get more frequently episodes of Braxton Hicks contractions that are coming more frequently. You also may have more vaginal discharge. Towards the end of your pregnancy, it is normal to have more vaginal discharge. So you may start seeing that. You may also lose your mucus plug. I tell everybody if you lose your mucus plug, it's okay. You don't have to come to the hospital unless you have a big gush of fluid like your water broke. Okay, so that may happen as we're getting closer to time. So that is that. Stages of labor. So there are 4 stages of labor. The first stage has 3 phases, so it's the longest stage of labor. The second is cervical dilation until the birth of your baby. The third is the placenta coming out, and then the 4th stage is the postpartum period. So factors that affect labor. Position of the baby's head, the size of the baby, what way the baby is laying in utero, size and shape of the mother's pelvis, how the mother is coping emotionally and physical, the effectiveness of contractions for dilation, the support person helping the patient, and then also medications and anesthesia. So descent through the baby's birth canal, so that cervix will thin out. You'll see membranes are bulging, the baby's head will face the mother's side. Cervix will fully dilate eventually. Baby begins to rotate towards the mother's back and their chin will be tucked. The rotation will be complete. Baby will be in the occiput anterior position. Start pushing, the baby's head will appear at the vagina, and that's called crowning. The head will come out, and you can see the head is out. The baby will extend their neck. We'll check to make sure there's no umbilical cord around their neck. And then the shoulders will come out, and that is called restitution, and your baby is born. So, comfort measures in labor. This can help you deal with labor discomfort and keep a level where you can manage with or without medication, okay? So relaxation, being able to really relax in between contractions, focus and distraction, doing those cleansing breaths, the rhythmic breathing, effleurage. Effleurage is where you take the palms of your hand. You want to do it kind of firm. You don't want to do it soft, but you don't want to do it hard. So just kind of firm, and you rub in like a circular motion when you're having a contraction, and it kind of helps distract your brain from that pain of the contraction. Pressure points, changing positions, warm water. We do have jacuzzi tubs here. You can use that as a pain management option. We don't let you have the baby in the tub, but you can use that as a labor pain management option as long as you are low risk and the provider says that that is okay. With back labor, lots of things to do with that is really kind of flipping on your sides and leaning over on the bed, maybe sitting on a birth ball. Aromatherapy, if you are into the essential oils, you can bring your own diffuser and you can use those as well. At the hospital, we do not provide birth balls, but if you have your own birth ball, you can bring it in and use it. So these are some of the comfort measures that we use. Okay, back labor, that is where most of those contractions are felt in your back, okay? That is when the baby is what we call sunny side up. So that means they're coming out, kind of looking at you, okay? So this part is coming out first, which that is the widest part of the head. So that's the hardest way to have a baby. So a lot of times if you are having more back labor or almost all in your back, your baby is coming out that way, okay? Best things to do for back labor is changing positions. That is huge. Going on one side all the way for a little bit, and then changing to the other side, and then massaging the back. Like she's in this picture, leaning over the bed on a birth ball is really good. Or if you don't have a birth ball, you can put the head of the bed all the way up and kind of lean over that too. That should help as well and kind of help get that pressure off of your back with the baby. Okay, the first stage of labor, so this is the longest stage, I kind of said before, early, active, and transition, okay? So early labor, mom is excited, eager, and social at this point. This is now where your cervix is closed till your cervix is 6 centimeters, okay? So early labor is closed, you're not dilated, to 6 centimeters. So this is the newest guideline that we have been following. It used to be 4 centimeters was active labor, but they changed it to 6, and that's actually helped to decrease our C-section rate and give you more time to labor in that early stage. In active labor, mom is no longer social. She's very involved with the work of labor, okay? So active labor is 6 to 8 centimeters, okay? That is when the widest part of the baby's head is in the widest part of the mother's pelvis and it's starting to move down. In transition, mom's focus is inward. I always kind of laugh at this one because transition is when you're 8 to 9, okay? If you have an epidural, a lot of times you look like that. If you don't, you're really breathing through them, okay? So if you don't have an epidural, you don't usually look like that in labor unless you're a rock star. I was not a rock star, unfortunately. But this is what transition is. It's usually 8 to 9, okay? Once you get to 10 centimeters, you are complete, okay? And that is when your cervix is fully dilated and that the baby can come out, all right? So second stage of labor is pushing and the birth, okay? So there's many different ways you can push. If you do choose to get an epidural, some of these positions are very hard to do up here because you are numb, all right? So we can try to do them with you, but if you're too numb, we can't. A lot of them we do where you're laying down with your feet up. I do tug of war with a lot of my patients. That's probably my favorite. Pushing, we play tug of war as you're pushing, and that kind of helps focus on you pushing and pulling at the same time. It's kind of a good distraction. Going on your side and pushing is one. We have a squat bar we can hook up if you want to do that as well. So there's many different ways that you can have your baby. Pushing. So when you are pushing, we will kind of go over this with you when it gets time, but what you want to do is kind of take a nice big deep breath like you're going underwater. You want to hold that breath and you want to put your chin to your chest and push like you're pooping, okay? You don't want to push in your face. Sometimes it's hard when you have an epidural because you can't feel that urge sometimes. So we'll kind of tell you, no, push down there, push down there. But you will take in that nice big deep breath in, hold it like you're going underwater, and then you're gonna push for 10 seconds. Your nurse or the provider will count for you. After that 10 seconds, you're gonna let out that breath. You're gonna take another one right back in, and you're gonna push. We usually do that 3 times, okay? So 3 cycles. If you're pushing really good, maybe have you do 4, okay? So this is the birth, okay?
Pushing with contractions may last from 1 to 3 hours. It's hard work. It's called labor for a reason.
Okay, and that was like really towards the end of birth, okay? So the third stage of labor is after the baby's born till the time the placenta comes out. You may still have to push a little bit for that placenta to come out, but it's definitely nowhere near as painful as the baby, okay? So that usually can take about 5 to 15 minutes. It sometimes can take a little bit longer. Your feelings and reactions, you may be, very, screaming with delight, crying because you're so happy your baby's finally here. You're probably really involved with the baby and focusing on the baby that you may not even really notice it very much, okay? Physical changes in mom, so you'll see slowing of contractions after birth and that uterus trying to clamp back down to its original size, okay? So that uterus is a big, huge muscle that we have. It is usually the size of your fist. With a baby, like I showed you with the baby, the placenta, and the water bag, that's a lot in that uterus, okay? So it's a big muscle that stretches out when you're pregnant. So after that baby comes out, we want it to kind of shrink back down so it doesn't bleed too much, okay? So your nurses will be checking your uterus to make sure it feels kind of like a softball in there or a grapefruit and doesn't feel like a wet sponge, okay? And if it feels like a wet sponge, it means you could be bleeding too much, and we want it to kind of firm up and feel like that softball, all right? So fourth stage of labor is the recovery after birth. It's a postpartum period, and that is for 6 weeks. Okay, medical interventions and C-section. So we are going to talk about that. So medical interventions may cause unexpected side effects that may lead to further interventions. Talk with your healthcare provider about any medication options. So medical interventions include how to induce labor, medications for pain relief, artificial rupture of membranes if we have to break your water, or continuous fetal monitoring in low-risk women. So medications for pain management, okay? There are a few options that we do offer. So analgesics or narcotics. So Tylenol we can use if you're in, early labor. If you're in, really severe pain with contractions, we do sometimes give Nubain or Dilaudid. That goes through your IV. That helps with that contraction pain. It kind of makes them feel a little bit less. It won't take them away, but it will help, lessen them up a little bit. We don't really use tranquilizers or sedatives. Sedatives, you may take like a Benadryl if you are going to be a long induction and you're not dilated and you're not sleeping. They may offer you that, but you'd have to talk to your provider about that. Regional anesthetics, so local anesthetics. Lidocaine we use a lot if you need stitches after delivery down on your perineum or in your vagina. They will numb you up. Epidurals we use for labor, and then spinals we use for C-section. If you do have an epidural, we can dose that up for a C-section if you have to have a C-section for a reason. So the epidurals do work for C-sections as well, okay? So what the epidural looks like, it's very flexible, okay? It's kind of like an IV catheter, all right? And this will go in to your back to a certain level to where the epidural space is. They will test it to make sure it is in the right spot, the anesthesiologist, and then we will tape this up to your back, okay? This will give you continuous medication throughout your labor, after delivery, and then once your placenta comes out. They also will keep this going till if you need stitches, they'll keep this on as well, okay? After that, then we turn it off. Once we turn that off, it still takes an hour or two to kind of get that full feeling back. So we don't want you getting up to go to the bathroom on your own for the first 2 times. We want to help you. Even though your legs may feel okay, they may not, and they may kind of buckle on you. So your nurse wants to help you. Also with the epidural, once you do have this in, you can't get up even if your legs feel okay, all right? So we'll be doing either emptying your bladder with a straight catheter, or they may put a catheter in to kind of keep your bladder draining continuously. That'll be up to your provider or midwife how they want to evaluate with that, okay? So the epidural and the spinal spaces are 2 different spaces that the anesthesiologist will use. Epidural is used mainly for laboring patients. The spinal is in the spinal fluid, and that can give pain relief for up to 2 hours during a C-section. There are different medications that they can put in there to make you comfortable for 12 to 24 hours after delivery, and your anesthesiologist will talk to you about that. So this shows the epidural.
Now's a good time to start thinking about pain control during labor. Several options are available to you, including intravenous pain medications and epidural anesthesia. Once the anesthesiologist has obtained your health history, it will go ahead and explain to you how he goes about placing the epidural. The process of placing the epidural will involve assistance from the nursing staff, having you sit up and assuming a position where you kind of relax your shoulders, let your head drop down to your chest, and you curl around your baby. Once you're in position, the anesthesiologist will clean your back off with some cold soap. He'll then go ahead and give you some numbing medication. And that first shot does sting a little bit, but it only lasts for a few seconds. Once the area is numb and the drapes are up, the anesthesiologist will place the epidural through a needle. The needle is placed, you should not feel much pain at all, maybe a little bit of pressure. Once the anesthesiologist gets to the right spot, he goes and threads a small catheter in, and the needles come out. The only thing remaining in the space is a small flexible catheter that you probably won't even know is there. Through that catheter, the anesthesiologist can give you pain medication continuously throughout your labor. When labor is over, the nurse will go ahead and discontinue and remove that catheter. Some of the side effects of the epidural, the anesthesiologist will explain these to you prior to placing it. There is a small risk, about 1 in 150, of having a headache after the placement of the epidural. And it's a type of headache that you won't get right away, but it would be a headache that you would get within 24 to 48 hours.
Okay, so the anesthesiologist will come in, they'll take a history, they'll talk to you about the benefits, the risks of the epidural, kind of like what he did, and then if you decide to do it, then we will go ahead and set you up for the epidural and go through that process with you. So fetal monitoring. So we have different ways of monitoring baby, okay? So in this picture, you can see the contraction monitor is here and the baby monitor is there. This is the external fetal monitor that we have. We use these bands. So usually you have one on for a contraction monitor and then one on for baby, okay? And these will stay on. The next one that we can use is our wireless monitor, and this is a patch that will go on your belly, and it just kind of sits there like this. These are little electrodes, and this monitors contractions and baby's heart rate and also mom's heart rate. Again, this is wireless, so sometimes they work really, really good, and sometimes they don't want to work very well. So this can be used on patients that are term. We cannot use this on twins. Okay, this monitor also can go into a shower. It just cannot be submerged in a tub. This allows you a little bit more freedom to kind of get up and move if it's working good. Okay. The other monitors that we may use are our internal monitors, and those monitors maybe use, sometimes we'll use like the internal fetal scalp electrode. If we aren't able to get baby's heartbeat very good, or we're having difficulty keeping baby on and your water is broke. So it's a little electrode that goes right underneath the top of their skin and will stay on, okay? It's right on their head. It does not hurt them, and this helps us kind of keep baby on better, okay? This is kind of something we use if we're having really kind of a difficulty keeping your baby on the monitor, okay? The next one that we use is our internal pressure catheter, and that is a catheter that is actually thread up your vagina, and it goes into your uterus, and it sits there, and it sits in the water, the amniotic fluid, and measures the pressure of each contraction, okay? So this is the only device that can tell us the true pressure and the true, how strong they truly are, okay? This is the only one. You may be having these huge, big contractions on the monitor, but they may be really mild when you palpate them, and they may not be doing anything. You could also have really tiny contractions, and they may be really strong. So the external monitor and our wireless monitor are just used to tell us when you're having contractions. They can't tell us how strong they actually are. This is the only one that can tell us how strong they are, okay? So those are the different types of monitoring that we do use. Induced labor. So induction of labor is generally reserved for those pregnancies with special medical problems or other problems going on, okay? So high blood pressure is one, diabetes, RH disease, if your baby's overdue, if your baby's very small or very big, or if your water broke. Those are just some of the main reasons that your provider may induce you, okay? So different types of induction agents that we use. It doesn't really go over that in the slide, so I'm gonna go over a few of them with you, okay? Again, everybody is different on how their provider will induce them. There's multiple factors that go into that, so just bear with me on that. Everyone is different, and also that you may get different things than your friend did or your sister or whatnot, okay? So the first one I'm going to show you is our Cervidil. This is kind of like a little piece of medicine, okay? It's kind of like a tampon that goes in your vagina. It goes up by your cervix, and this can stay in for 12 hours, okay? What this is made to do, it's a prostaglandin, okay? It's cervical ripening. We want that to kind of thin out your cervix, okay? So they'll use this a lot, if you're 1 centimeter closed, your cervix is still pretty thick, they'll put this in, okay? And this, again, will not set you into labor. It can, But the purpose of it is to thin out your cervix, soften it up, okay? This can cause contractions. It may start to have you contract, and it may cause you to go in labor. But the main purpose is for it to thin out your cervix and make it more soft, all right? The next one that we have, I don't have it with me. It's a small little pill, okay? Super small. We cut it into a fourth, okay? So it's very, very tiny. We'll put that up in your cervix, or sometimes they have you take it orally, all right? That is also a cervical ripening agent. It's called Cytotec. We may use that as well. That is the same thing as Cervidil, but you can have it every 4 to 6 hours, depending on what your provider orders, okay? Same thing. We want it to soften that cervix, thin it out. It may cause you to have some cramping or start having contractions. It also can cause you to go into labor, okay? The main purpose of it is to soften and efface that cervix, okay? The next thing that you may get are our balloons, okay? So this is one of the balloons that you may get. It's kind of like it is like a catheter that goes in your bladder, but it's a lot bigger one, okay? What this does is this gets put up into your uterus by your provider. Sometimes they'll use like a speculum to get it up there, or a little ring to kind of guide it up there, okay? Then what they will do is they put it inside the uterus, they inflate the balloon, usually with 60 cc's, so about 2 ounces of water, and then we kind of put some tension on this, and we'll tape it to the inside of your leg, all right? We're not gonna pull super hard, all right? That's not nice. But we want just a little bit of tension to kind of help dilate and thin out that cervix, okay? This can stay in for up to 12 hours. It usually falls out after a few hours or so, okay? But what this does, after it is out, your cervix is usually 3 to 4 centimeters dilated. So that is one of the balloons. The other balloon that we also use as well, it has actually 2 balloons that we blow up. So this one gets taken into your vagina, into your uterus. The top balloon gets inflated usually with about 60 cc's or 2 ounces of water. The bottom one sits in the bottom, like by the bottom of your cervix, and that one usually gets inflated with about 1 ounce of water. So your cervix is in between these two, and we do the same thing. We put pressure on it, tape it to the inside of your leg, and then when this falls out, you're about 3 to 4 centimeters as well. So there's 3 different ports on this, one for uterus, one for vagina, and then we also have, this is for the stylet, because these are a little bit more flimsy than these ones, okay? So your provider has a different preference, then that is the one that they will use. So those are the cervical ripening agents. The next thing we can do is if you come in and you're contracting, you're like 3 centimeters, you're not really making any change, they could break your water. That's one option that they could do. Your provider would discuss that with you if it was appropriate timing. The other thing we can do is Pitocin. So Pitocin it's on a pump. It's a titratable drug. Your nurse can titrate it. We get orders from the provider for how they want us to do that, and then we can start doing that process, okay? Some people need a little bit of Pitocin. Some people need a lot of Pitocin. Everybody's different. Every baby's different. So we kind of start doing that process. Your nurse will up your Pitocin when it's time to do that. Sometimes there's a while that we don't up it because you're contracting really good, you're in labor, and sometimes you kind of start petering out. We may have to up it again. So your nurse will kind of titrate that as necessary. Okay, so those are the different induction agents that we do have here. And that just kind of goes over, rupturing the bag of water. We showed you the amni hook earlier. Assisted birth. So, episiotomy. That is the cut in the perineum that is located between the vagina and the rectum, okay? There's 2 different ones. There's one that is a midline that just goes straight down, and then there's one that can go medial lateral, which kind of goes to the side, okay? Your provider will do that if they think it is necessary to get the baby out safely, okay? If they feel you are going to tear from, your vagina to your rectum, they may do that to kind of help prevent that tearing, okay? We would rather have you tear on your own, but if that were the case, they want to do that to kind of help you prevent from that actually happening, okay? Forceps. Forceps we can use, they go on the baby's head. That is not done as frequently. I've seen it maybe 5 or 6 times in my 10 years here, but they are used occasionally. Common uses for forceps are maternal exhaustion, mom's not pushing good, baby's head is in the posterior position, fetal distress. So it's quicker to put the forceps on than take you back for emergency C-section. So that would be reasons for forceps. A vacuum, it's not like a Hoover vacuum, it is like a suction cup, okay? This vacuum that we use is actually, it's called a Kiwi, all right? So what they'll do, there's a nice little foam pad in there, so it's not hard on baby's head. They'll put it on the baby's head, okay? And then here, there's a pressure gauge. They pump it up to a certain pressure, and then it pulls and suctions to the baby's head so we can get baby out, okay? These are used a lot more than the forceps. These aren't used all the time, but they are used, they're the common one used if we need to get baby out in an emergency, opposed to the forceps. So, cesarean births, those are performed when a vaginal delivery isn't possible or there's concern for well-being of mom or baby, okay? So some of the common reasons for C-sections: failure to progress in labor, irregular heartbeat, your baby's not tolerating contractions, position of the baby if your baby is breech, or if you've had a previous cesarean section. Other reasons for C-section birth: if your placenta or cord problems. So if your placenta is over your cervix or you have a placenta that's tearing away from your uterus, that would be a reason for a C-section. Or if you have cephalopelvic disproportion, that's where you have very narrow pelvis. This is what a C-section is. Okay, so that is what a C-section process kind of is like. So if you have a C-section, say you're scheduled for a C-section, your baby is breech, okay? You'll come in usually 2 hours beforehand. We'll start an IV. If we have to draw labs, we'll get labs. Anesthesia will come in and see you. Your doctor will come in and see you. We'll get your support person scrubbed so they can go back with you, get pre-op meds ordered, and then once it's time to go, we'll bring you back to our OR. What that means is you come with your nurse back to the operating room on L&D. Your support person will wait in the room or in our recovery room. We will get you into the room. We'll get your blood pressure cuff on, your oxygen sensor that goes on your finger on. You'll sit up for your spinal. Your anesthesiologist will get that in. The spinal is actually very quick. You start getting numb pretty fast from that. We'll lay you down after that is in. We'll put on leads for your heart rate. We will put on a pad on your leg. We also then will put your catheter in. Usually by the time we get those leads and stuff on, you're pretty numb. You shouldn't feel the catheter at all, okay? Then we will put a blanket on your legs. We'll scrub your belly. That takes about 3 minutes to dry. That's usually the longest time. And then once that is dried, your doctors will have a drape. They'll put the drape on, get everything set up. They'll test to make sure you're nice and numb. Once they test, then we will go get your support person. There is a chair up next to the head of the bed. That is where the support person will stay and sit down with you and be there with you. There is a little clear bag that they will give you for pictures. We can take pictures after the baby's out once baby is stabilized and all that. NICU team comes to every delivery at the hospital here. So we have a neonatologist or a nurse practitioner, a nurse, and then a respiratory therapist. They come whether your baby is term or preterm. They will make sure baby's good, assign those APGAR scores, usually do the weight, and then if mom is feeling okay, we'll put baby skin to skin with mom, usually like right in this area, okay? I know you're laying flat, so sometimes it's a little bit hard and you feel uncomfortable doing skin to skin. If you do not want to do that, we can wrap baby up and get baby to your support person and start that skin to skin process once you get into a recovery room, okay? The support person that you have is the only one that can be with you the whole time that you are here. We only allow one person into our recovery room, even when we are not on visiting restrictions. Just because you're recovering from surgery, it's a major surgery. Sometimes, you know, you're a little nauseated or we have to give you something for pain. So we don't want a lot of visitors back there, okay? Other reasons for a C-section, so face or brow presentation. And what that kind of looks like is the baby is coming out looking like this. Then. Like that, okay? And that baby can't come out like that, all right? It'll hurt their neck. So that would be a reason for a C-section as well. Transverse lie, they can't come out back first. Types of breech, these are different types of breech presentations. Baby can't come out breech. Placenta previa, that is where that placenta is covering the cervix. We can't have that placenta come out before baby. That is the baby's lifeline, okay? Abruption, if you have a really bad abruption, they will give you a C-section. And that is where that placenta is tearing away from the uterus. A prolapsed cord, that is when the umbilical cord is coming out first, okay? That is an emergency, and it's a very quick emergency that we get that baby out fast. All right, maternal complications. So some of the reasons a cesarean would be performed for health risks. So a very premature infant, maternal heart condition, very poor diabetes, severe preeclampsia or toxemia in pregnancy, very high blood pressure, if there's an active case of genital herpes, multiple gestation for twins or triplets, prolonged rupture of membranes, if you've been ruptured for a long time and you start getting an infection, ineffective contractions or you're not progressing in labor, or if you've had a previous C-section with a vertical incision on your uterus, okay? These are the types of incisions for the uterus. The low transverse, you'd have to talk to your provider about doing a vaginal birth after a C-section if that is something that they are willing to do and if you are a candidate for that. But that is the type of incision on your uterus that you could have a VBAC if you have a C-section first. This one you absolutely cannot. That is a vertical incision. The reason being is because the uterus has muscle fibers that are kind of like this. If you are contracting like that, your uterus has more chance of rupturing and breaking open, okay? If it's just on that lower uterine segment, it's not gonna pull apart, okay? So that is the different types of incisions on the uterus. Preparing for a C-section, so the actual delivery only takes a few minutes. It's stitching everything up after delivery that takes the longest. Usually you're in there about an hour or so once we step in there till when you get in a recovery room. So post-operative recovery, remember this is a major surgery. The recovery period will take longer than a vaginal birth, okay? So some of the issues that you may have after a C-section is gas pains. You may have pain when you cough and deep breathe. I tell patients to take a pillow and kind of splint that incision if they have to cough. That kind of helps put that pressure on that incision and doesn't hurt as bad. You may have incisional pain, and that's more of that burning pain from those nerve endings that were cut with that incision. Ice helps that a lot. You will have a catheter in usually for the first 12 hours, and then your nurse will take that out. Vaginal discharge, you still will have bleeding after delivery, just like you do after vaginal delivery. IV, you will have an IV in. So there are stuff after a C-section that is a little bit more than a vaginal delivery. But don't lose sight that you have accomplished and received the most beautiful gift, your baby. Okay, I am done. Thank you so much for joining us today. Allie is actually going to teach this last part of the class for us. So I hope all of you have a safe pregnancy, and we see you very soon.
All right, hello, I'm Allie. I have been a labor and delivery nurse for 6 years now. Before I came to labor and delivery, I worked in the clinic. So I was in like your provider's clinic as a nurse there. I'm a member of the maternal transport team, so I go out to outlying hospitals and get our moms who need a higher level of care. I have 2 children, so I'm able to also help you with your labor and delivery process. So my portion of this, we're going to talk about the adjustment to parenting. So some changes to expect after birth. In the 4 to 6 weeks following the birth of your baby, your body is going to slowly adjust back down to what we call post or pre-pregnancy. The amount of time for this process, it always varies, but the first 6 weeks following your birth is also called the postpartum period. So your uterus and your cervix and your vagina, everything's going to shrink back down to normal. Your bladder is hopefully going to be able to give you a little bit more room so you're not running to the bathroom multiple times. So the postpartum period, it always involves the mom progressing through many changes emotionally and physically, okay? No amount of study, practice, classes, anything that we're going to be able to tell you is going to prepare you for parenthood. So we're just here to kind of help you along the way. So according to postpartum support groups, as many as 1 in 8 women may experience emotional symptoms. Postpartum depression is the most well-known of these conditions. So if you have any trouble sleeping too much, changes in your appetite, feeling exhausted, pain with moving, feelings of being a bad mother, lack of interest in the baby, or thoughts of harming yourself or the baby, please let us know. Call your provider immediately. Support people, this is also important for you guys to be aware of. If you start noticing some changes, it's very important to be aware of this so you can help them kind of think of this. So the new dad. So there are many ways for you guys to also be part of this baby. So sometimes you think, oh, mom's breastfeeding, I have really no role in this at all. But in fact, you do. Snuggling skin to skin. So that skin to skin is really good for baby, even with mom as well as you. Burping the baby, changing diapers. You can bathe the baby, play with the baby, take the baby for a walk. So just kind of things that you can do when you come home from work and kind of give mom her me time. Some self-care hints for mom. So make sure you guys have simple meals and a flexible dinner routine, home routine. It never fails that when you sit down to eat dinner, baby's also going to be hungry, okay? So kind of be flexible with this. Get help with shopping and cooking. Friends and family to care for other children if you guys have them, or even if they want to come over and offer to vacuum your floors or do whatever, kind of let them do it, okay? Postponement of major household projects. Let's not do a whole full house remodel right before you're going to bring your baby home. And always ask for what you need. Everybody is always willing to help, so never feel like you're being a burden to them. All right? So nutrition. So again, while you're in the postpartum period and you're breastfeeding, the food guide states that you should have a 2,000 calorie diet. And they also state that you should avoid fish with high mercury content like shark, tilefish, mackerel, and swordfish. The importance of omega-3 in your diet. So most of you are taking a prenatal vitamin right now with the DHA, whether it's in your prenatal vitamin or a separate vitamin that you take with it. And so that's very important as well after you have the baby. It becomes a major building block in eye and brain tissue development. So they say that in increasing the amount of omega-3s in the diet has been associated to reduce the risk of premature birth. It also helps reduce the risk of heart disease in mom. It maintains a better mood throughout pregnancy and postpartum. And it helps lower the bad cholesterol and raise the good cholesterol. Breastfeeding your newborn. So breastfeeding is going to promote wellness in your baby due to the presence of antibodies in the breast milk. Exclusive breastfeeding your baby is when the baby is fed only breast milk for the first 6 months of life. And then it's still considered exclusive breastfeeding as well up to a year if you just add in like the baby foods and things like that, okay? But when we say exclusively breastfeeding, we're talking about just breast milk only for the first 6 months of life. So in order to support breastfeeding, we do like the skin to skin immediately after birth. And the babies are thought to do what we call kind of like a frog, where they're going to go and get themselves down to the breast milk, okay? They can smell you. They know your smell from being in utero. So we also are educated to help you. We have lactation consultants on staff. Our labor and delivery nurses are educated on helping to initiate breastfeeding. And then our lactation consultants can come see you on labor and delivery, but they will also see you on mom baby, okay? We can do breastfeeding support group meetings. We are not meeting in person right now due to the quarantine that we're all in. But we do have many people that are available to help you, okay? You can call in and contact us. So the anatomy of the breast. So the areola is the dark area around the nipple. We have the nipple, and then all of your milk ducts are from behind, okay? So when you first start breastfeeding, you're going to think, oh, I don't have any milk, but actually you do. And then on day like 3 to 5, you will start what we call engorgement, and you will get a majority of your milk coming in. And so then you're going to see your breasts enlarge. So again, with the exclusive breastfeeding, so UNICEF and the World Health Organization recommends exclusively breastfeeding for the first 6 months of the baby's life. It's based on scientific evidence for the benefits of infant survival and proper growth and development. Breast milk provides all the nutrients an infant needs during the first 6 months of life. One thing I do want to let you know is when you are breastfeeding, so when the baby's saliva mixes with your nipple, like during that suction process, if your baby needs more iron, your breast is going to make more iron for the baby. If your baby needs more vitamin D or whatever your baby needs, that saliva and the nipple talk to each other. So that way they can, it conforms to exactly what your baby needs. So it's very important for you to get all the facts you can about breastfeeding, and we are here to help you with that. So some benefits of breastfeeding for the mom: very convenient and economical. Never have to worry about packing something to eat for the baby because you're always right there and you got it. Helpful with the process of the uterus returning to normal size. During breastfeeding, your uterus automatically contracts down, so it's very helpful in helping the uterus return to its normal size. Helps with weight loss. It reduces the risk of osteoporosis. As a mom, you are less likely to develop ovarian, breast, endometrial, uterine cancer, and it's going to reduce the risk of your heart disease. As far as for baby, it's easily digested. The perfectly matched nutrition, like I just talked about, when the saliva and the nipple communicate with each other. It has protective effect against SIDS. It reduces the risk of like GI upset, ear infections, respiratory infections, and allergies. It also helps the baby stimulate their sense of taste and smell. It's filled with antibodies that protect against infection, and it can reduce the risk of certain chronic diseases and infections. And the baby receives skin to skin and eye and voice contact during that breastfeeding. Benefits of breastfeeding for both the mom and the baby. It's going to contribute to a very special and loving relationship, and it's a beautiful way for you to kind of learn your baby's needs, okay? You're going to learn your baby's touch and to bond with your baby. It saves you money. It's healthy for the environment, and families can always get on the move readily because your breast milk is always there, fresh and ready whenever you need it. So that skin-to-skin connection is the unwrapped baby lying directly on your skin, and it really helps to calm the baby and yourself. So if you find that your baby's really, really fussy and you're trying to breastfeed, we recommend that you unwrap the baby, let the baby lay with you belly to belly, skin to skin, and try to calm down first, because this initial snuggling also has important health benefits, but also a baby who is upset and crying is not going to have a good latch. So in the very beginning, we recommend that when you are going to start breastfeeding, make sure baby is nice and calm. So the skin-to-skin contact immediately after birth, it helps to stabilize a normal skin temperature. It helps to stabilize the blood glucose level, all of the vitals for the baby. The babies cry less, they latch better, and it is shown to have you exclusively breastfeed longer. Keep in mind that fathers and other family members can bond with the new baby through skin-to-skin contact. So this is special bonds for the whole entire family. So your touch is how you communicate with your child. Anybody ever had a hug from somebody and it just kind of gave you that sense of peace? That is how your baby is learning how to bond with you, okay? So your touch is a very important part of bonding at birth and beyond. So if you do have a premature baby, our NICU actually offers what's called kangaroo care. So as long as baby is okay and they allow this, we have seen like where the babies can have it can reduce their need for oxygen when you do this kangaroo care. We just ask that when you do it in our NICU, that it's for an extended period of time. Because as you can see here, this baby has a nasal cannula for oxygen. So it's a lot of wires and you're gonna be sitting close, but we just like it to be for an extended period of time. That way we're not moving all the wires and adjusting everything for a short amount of time for skin to skin. So colostrum, we call this our liquid gold. This is what you're gonna have for the first few days of breastfeeding, and that's why you're not going to think that you're going to think that you don't have milk, is because this is very high in protein. It's easily digested. It provides protection against infection, and it's going to coat the stomach and the intestines to protect it against any invading organisms. So mature milk starts being produced at about 48 to 72 hours. And that mature milk is what has the water, the carbs, the protein, and the fats that are necessary for growth and energy for the baby. So in preparing for breastfeeding, education is the best preparation. So you guys are already accomplishing step 1 with your education. If you're leaking colostrum, you may want to start putting pads in your bra. We do ask that you don't put like mini pads or period pads, if you will, in your bra, because they do have chemicals in them, okay? Have someone knowledgeable about nursing bras that can help you purchase the bra that fits well. Again, as Ashley stated earlier, we do not want underwires, okay? That just kind of confines your milk ducts to only a certain amount, so we want you to be able to have all the milk that you can. You may find that you'll need to buy a bra that is 1 to 2 cup sizes larger, and that's okay. So the 3 C's of breastfeeding, you want to be calm. So again, like holding your baby skin to skin so you can both be calm during the initial latch. Comfortable, have pillows all around you. If you need like the nursing pillow, which is like the U shape to go around. And close, make sure you're holding that baby close to you and skin to skin so that everybody can be nice and calm, and proper positioning and latch are the keys to successful breastfeeding. So becoming acquainted with your baby's going to start showing you cues and signs within minutes after birth. So kind of pay attention to that in that first postpartum period, like the 2-hour recovery period when you're on labor and delivery. Babies are going to start showing you what they're going to do for like hand to mouth to show you that they're hungry or whatever. So for rooming in the hospital, as Ashley had stated in the beginning portion of this movie or video, that we baby basically stays with you all the time unless they're going to leave for advanced medical help or circumcision. So never be afraid to call us for help. We do not want you to leave your baby unattended for any reason. If you have to get in the shower, just roll the bassinet into the bathroom, or even leave the door open and just to where you can see the baby if you look out. Keep the baby close to your bed and furthest from the door. So in our rooms, your bed is closest to the door, so just make sure you keep the baby on the other side. Don't give don't give your baby to anyone you don't know. And always check for personal identification. Again, Ashley had talked about the purple around our badges. So everybody who deals with babies and infants have the purple around their badges, and anyone else, such as your pediatrician, will have the blue. But you'll know if it's your pediatrician, or they'll introduce yourself. But you can always ask them, okay? Never be afraid to ask. So breastfeeding when and how. So research has shown that the baby is in a state of quiet alertness for the first 2 hours after birth. So we're going to try to get you breastfeeding during that time. And I shouldn't say try. We are going to work really hard to get it done. So 99% of the time it happens. So feeding cues. So we're going to teach you for newborn care to swaddle your baby. But also start watching during that swaddling. If the baby starts moving their head from side to side, or if the baby's not swaddled, they're going to bring their hands to their mouth and start sucking on their lips or their tongue during sleep. Fussing or fidgeting while sleeping are all signs that the baby's going to be ready to eat. So the proper positioning and latch on are key. So that's very, very, very important. So the correct latch, you're going to want to get all of the areola into the mouth. So as you're laying stomach to stomach with your baby, so you always want to be skin to skin and stomach to stomach with your baby. And what I like to say is the special K of the baby, that's how you're going to want the latch on to be, okay? So you're going to want a real wide mouth, and you're going to want the lips flanged out and turned out, and the tongue is going to be down. So you're not going to want to wipe your nipple across the baby's cheek, because that baby is going to turn towards that, okay? So you want to wipe the nipple down and put the tongue over the lower gum and then latch the baby. Again, you want most of your areola in that baby's mouth, so that way, as the picture showed, it gets your milk ducts and it stimulates your milk ducts for the production. You're going to want to listen and watch for milk transfer and swallowing. Again, a good positioning facilitates a good latch.
You can hear her sucking and you hear her swallowing. So you can put her head into the crook of your arm here, right there, great. And then you want to turn her to face you, perfect. You can just tuck that little hand underneath so it's out of the way, good. And you have her in nice and close, kind of tummy to tummy with you. You can hear her sucking and swallowing, so you know she's getting that milk. So you could see when she was latching on, it was real important to just make sure that you were stroking her lip, and when she opened up nice and wide, you really want her to get most of the areola, which is that brown coloring around your nipple. You want her to really get most of that into her mouth, which she's doing a great job. And then once she's latched on, you can feel a little bit of tugging at your breast, but it should never hurt as you nurse when the baby's latched on well. So having her open up nice and wide is real important. And then you're holding her nice and close, and it's great you use this pillow because support for her, and having her nice and close to you will help her have good latch on. And you bring this hand around, and that's perfect the way you're holding her. You never want to hold her up on the back of her head because she'll tend to push back against that. So that's perfect, and you just support your right breast and stroke her lip. Great. And then as you stroke her lip and she opens up nice and wide, that's how she gets more breast tissue in her mouth. And you can hear her sucking and swallowing. perfect, so you know she's getting that milk. You're doing a great job. And it's perfect the way you're holding her in nice and close, and continuing to support your breast helps for her to stay latched on well, so that's perfect. And sometimes she'll take a little rest like that. She'll suck, and then sometimes rest a little bit, and then suck. So that's just perfect. And this is a really nice position because you can see her latched well. So it's a nice position for a first-time mom, that cross cradle hold, because you can really see her latching on well.
All right, so we will go through all the positioning coming up, and that's why I have my chunky little baby here to help show you guys. So the steps to follow for a proper latch on, as they said, wash your hands, get real comfortable, and you're going to want to decide on a feeding position. You can try all these feeding positions. I encourage you to try them all because I want you to be able to do what's most comfortable for you. So you're going to align the baby's chest to your tummy, okay, and align the nose to the nipple. And then you're going to hold your breast and gently lift and support. So you can either hold or you can hold like this, okay? So these are like the difference in positioning. You're going to run your nipple lightly on the baby's upper lip. And when the baby opens the widest, that's when you're going to put the baby to your breast, okay? As they said, it should not hurt and there should not be any noise besides swallowing. You don't want like any sucking noises or anything like that. That means that there's not a good latch. So you're going to want to aim the nipple towards the roof of the baby's mouth. The baby's chin is going to come to the breast first, and that's how you're going to get the good latch on, because they're going to latch on to the majority of the areola, and that's what's going to help the milk production, okay? The lower lip is going to be positioned further from the nipple than the top left, and this is the off-centered latch. Again, that's so that they can get the majority, the top part of their mouth over the majority of your areola to help initiate that milk transfer. When your baby opens wide, you're going to pull them in. A good latch is a learned response, so be patient with yourself and your baby. Your baby can feel if you're a little bit excited or nervous or worried about this milk transfer. So again, I really strongly suggest that you do the skin-to-skin contact and just try to remain calm, okay? This is a learned thing for both you and your baby. So remember, a correct latch on is a learned response, so be patient with yourself and your baby. So to remove the baby from the breast, you're never going to want to just pull them off of the breast, okay? Because that's going to leave you with sore nipples, and sore nipples leads you to not wanting to breastfeed, or it can inhibit you like with your milk transfer, okay? So you're going to stick the corner, your pinky finger in the corner of their mouth, and that's going to release the suction, and then you can take them off the breast. For burping, so when they're real tiny, like this is super hard because they just want to scrunch up, okay? So setting them up like this to burp is super hard. Lying on them on your belly across your lap and supporting their neck, that could work as they're super small, or sitting in your lap with their chin supported, okay? So any way to get them to burp. So a baby that has air in their belly is going to pretend that they're hungry. They're going to think that they're hungry because their belly hurts, but it's just a burp, okay? So burping's pretty important. Okay, so the different positions, like I said, you're going to find what's going to work best for you and your baby, and it may change as the baby gets older, okay? That's why we really want you to be open and just try different things. So the laid back position, or the baby led latch, this is that natural position that you're going to do at first when you're skin to skin with the baby. So the baby is just on your skin, you're just kind of hanging out there right after your delivery, and baby's going to start what we call, we kind of call it like the frog. They're going to kind of just start bobbing their head all over the place until they can find your nipple. So us as nurses and you as a mom, when you see that, you can always ask the nurse for help if she doesn't see it right away or she's not in the room, or us as nurses are going to help you to get latched, okay? So the cradle position, this is the classic position, okay? And I bet if a lot of you have seen people breastfeed, you're going to see them like this. And this is called the classic, and this is usually the most comfortable position for mom and baby. The cross cradle is, again, a cradle position. However, you're going to hold the baby's head with your opposite hand, and you always want to hold around the neck. As they stated in the video, if you hold the baby on the head, their reflex is to push back. So you always want to hold them right at the neck, and then you're going to support your breast with the hand that's closest to you, okay? The clutch hold or the football hold, so like you're carrying a football, okay? You're going to put the baby in, and this is also good for warmth, and it kind of tucks their legs behind, and it has better help for you to keep this baby's hands down, because they're in utero for 9 months. They're used to just sucking on their hands, so the hand control is going to be a big thing for you with breastfeeding. So you're just going to hold them like this, and then place them on your breast. The side lying position, this is while you're laying in bed and you're just going to lay on the side. You're going to feed them on the side that's closest to the bed. I recommend this as they're older, to where they're able to be like roll around or do whatever, because when you're laying down like this and they're really tiny, you don't have a very good head control and being on a soft surface. So wait till they're a little bit older, like 6 months or so, where they have really good head control. So making sure your baby receives the feedings they need. Most babies are going to feed like 8 to 12 times in a 24-hour period. It's usually like every 3 to 4 hours. If they feed more than that, fine. All they're doing when they feed more is building your milk supply to what they need. Okay, so they're going to realize, oh, hey, I need some more milk during each feeding. So they're going to want to feed more, and that's just their natural instinct. Sorry, I hit that too fast, but cluster feeding. So when babies cluster feed, again, they're just building up your milk supply to what they need, okay? So in the early days, babies are going to be super sleepy. They're going to sleep the majority of the day. So you're going to really want to watch for feeding cues. Put the baby skin to skin to encourage the breastfeeding. You're going to want to keep them interested and awake during feedings. And you can also massage and compress your breast during the feeding to increase milk flow. Being that we're not in class and you're not really able to see this, when you come in, feel free to ask us to show you, and we will show you how to massage and compress your breasts and how to hand express. But like I said, being that we're just on a video, we will show you all of that in person as well. So you're going to want to nurse until the baby shows signs of being full. And signs of being full is your breast is going to become less full. The baby's going to be sleeping and start relaxing their body. They're going to suck less vigorously. And some of them, most all of them, will self-detach when they're all done. Okay? As you get further into your breastfeeding process, you're going to notice that your breast is less full. If they only nurse on one side, you will become lopsided. Okay? That's not just a joke that everybody talks about when you're breastfeeding, but it does happen. So again, you're going to want to offer both breasts at each feeding. Some babies will take both breasts, and some babies they'll be satisfied with just the one. So that's where the lopsided comes into play. And just remember, you're going to want to start on the opposite side the next time. Some moms will put like a safety pin on one side or the other, but as you get further into your breastfeeding process, you will notice that one is heavier than the other. So just always remember to start on the heavier one. Again, alternate the breast in which you begin. How do you know your baby's going to get enough to eat? They're going to be eating at least 8 to 12 times every 24 hours, and you're going to watch for feeding cues. Also, it's going to talk about the wet diapers. So because your colostrum is very high in protein and not so high in water, the first few days, you're only going to have like one wet diaper in the first 24 hours, 2 on the second day of life, 3 on the third day of life. Then as that milk starts coming in that's high in the water, the protein and the carbs, then you're going to start getting the 6 to 8 wet diapers of urine that are light yellow in color once your milk is in greater supply. Also, the baby's going to pass meconium. So the meconium is that sticky black substance that the baby passes from their bowels the first 1 to 2 days of life. And then the stools are going to change to like a mustard color. They're going to look like mustard. They're going to be seedy. And 3 to 4 of these stools beginning by day 4 in the first month, that's okay. Most breastfed babies will stool a little bit after each feeding. So weight gain is another clue that's telling your baby's healthcare provider and you that your baby is feeding properly. So the baby's going to lose a portion of their birth weight before they go home. And so then they're going to gain 4 to 7 ounces per week once the milk is in greater supply. They'll be back to their birth weight by day 10 of life, okay? Other signs, you're going to hear them swallow. The breast will feel less full and your baby is satisfied after eating. Another sign of being full is they're gonna fall asleep, their whole body's gonna relax, and they're gonna open their fists. So a lot of babies, when they're breastfeeding, their fists are real tight. And as they're feeling full or satisfied, their body's gonna relax, so their fists will open. They're gonna relax their forehead and they will let go of your nipple. So again, this is a hand expression. So we will show you how to do this when you're here. But hand expression is a real good way to remove milk from your breast without having the baby eat or using a pump. Okay, so some moms, if the baby's like that first night that they sleep through the night, you're gonna wake up and your breast is gonna be so engorged that you're not gonna be able to latch. The baby will not be able to latch because the areola is so taut from the breast being so full. So we encourage you to hand express. And if you choose to save it, you're gonna wanna use like a large, wide open mouth container in order for you to hand express into. So we're gonna remove your bra or any tight clothing. We're gonna wash your hands well and choose a relaxing place to position a warm, wet towel on your breast and massage to encourage the milk flow. But you're gonna place your thumb and your fingers around the areola. You're gonna press it to your chest, compress down, and you're gonna pull your nipple back out. That is hand expression, and that's what's gonna help you to be able to express milk without having the baby or the pump. And it's also gonna allow for your baby to have a good latch on after that, after you've been away or haven't fed for a while, okay? Like this says, it's going to be very beneficial for you to have your lactation consultant show you or your nurse show you how to do this when you're here with us, okay? So storing breast milk, you want to store it in like 2 to 4 ounce portions. 2 ounce portions when the babies are small. As they start eating more, then you can do 4 ounce portions. You always want to cool the milk before you're going to add it to frozen milk, okay? So you never want to add room temperature to frozen milk to have it be froze again. It always needs to be cool. And if you're going to add milk to the frozen milk, make sure it's a smaller amount. So like if you have 4 ounces, only add like 2 to 3 ounces if that's what you're wanting to do. You always want to leave a 1-inch space at the top of your container when freezing. Don't refreeze the breast milk once it's thawed. So once it's thawed, you got to use it or it's no good. Put the containers at the back of the fridge or the freezer where it's the coldest. And you're going to want to label the container because when you're away, you're going to want to use the oldest one first, okay? Be sure to throw out any remaining breast milk that was left over and not used from a feeding after it was thawed and warmed. So this is kind of neat. This is a very informative slide here. So if you're pumping or expressing breast milk, it's good for 6 to 8 hours at room temperature. Okay, you're gonna wanna cover the container and keep it cool as possible, but it can stay at room temperature for 6 to 8 hours. It can stay in an insulated cooler bag for 24 and a refrigerator for 5 days. Now, when we talk about in the freezer, so a freezer compartment of a refrigerator, it's good for 2 weeks. In the freezer compartment of a refrigerator with separate doors, it's good for 3 to 6 months. And a chest or upright deep freezer, it's good for up to a year. So when you're warming up the breast milk or thawing it, you want to check the date. Make sure you're using the earliest date, so the one that's furthest away. You're going to thaw the frozen breast milk by leaving it in the fridge for 4 hours. So when you're getting up and getting prepared to go to work or taking the baby to the babysitter or whatever you're doing, you're going to want to get that breast milk out right away because you want to have it thawed for at least 4 hours before. Place it in cool running water. You're never going to want to put it in warm water until after you place it in cool water, but you're never going to thaw it at room temperature, and don't thaw it on the stove or in a microwave, okay? Common nipple concerns are sore nipples and cracked nipples, and that comes from an improper latch. So that's why we're really paying attention to that latch, and we don't want to hear noise. We don't want to hear anything but swallowing, because that's going to lead to your sore and cracked nipples. Your black ducts and your mastitis, that is something that if the baby's not feeding as well or not emptying the breast as well, that's something that could happen from that. Engorgement. So this is what happens in like the 3 to 4 days postpartum when your milk comes in. Okay, there's lots of increased blood flow, there's swelling around the tissue, and your milk is coming in from all those times of breastfeeding that your baby's building up for you. The swelling will usually lessen about 24 to 48 hours from that initial time. Mastitis, this is an infection of the tissue surrounding the black duct. So it's usually red, it's very sore, it's a hard area. There's like a streak that you will see on your breast, and that kind of indicates that it's mastitis. You're gonna feel like you have the flu. You're gonna have fevers and chills, body aches. The treatment for it is antibiotics. You're gonna start antibiotics, and it's gonna be to nurse frequently. As much as it hurts, getting to be able to nurse and applying warm compresses to the area to help loosen up and alleviate that black duct, to alleviate the infection, okay? You're gonna massage while nursing. Cold compresses after feeding, get plenty of rest, and drink plenty of fluids, okay? But you will feel like you have the flu, body aches, fever, chills. That's why we'll start you on antibiotics and then continue to breastfeed. So the dietary requirements for the mothers that are breastfeeding, an additional 500 calories per day. So your milk production is independent to what you eat the first 4 weeks because it derives from the calories it needs from the fat accumulated from the pregnancy. So that first 4 weeks after delivery is very important as to how your milk production is gonna happen, okay? Going back to work and continuing to breastfeed, discuss the needs with your employer. You're gonna wanna organize your day to incorporate regular pumping sessions. Wear comfortable clothes with easy access for pumping. Find a place to store your breast milk. Take healthy snacks and drink plenty of water. Your employer has to give you a place to pump, and it cannot be a bathroom, okay? So this is important to talk about with them and know that they have to give you some place to pump. The note to dad. So like I said before, some dads feel very, let's say useless for lack of a better term, because they're not able to feed the baby when mom is around and mom's home with that baby for that first 6 to 12 weeks. But dads, you are important. So be patient with yourself and your partner. As mom's getting ready to go back to work, you know, you could be involved in potentially trying out that bottle to make sure that works for baby. But even just bath time or play time or whatever to give mom a chance to get in the shower or go have some me time, that's going to be your important role. All right, so caring for your newborn. So when the babies are born, we give them what's called an APGAR. We evaluate this at 1 minute and 5 minutes of life. A lot of people think that we're shouting out the weight, but unfortunately that weight is held off till about that hour of skin to skin, okay? So the baby's evaluated in heart rate, color, breathing, muscle tone, and reflexes. Babies do not get a 10. It's very rare that babies get a 10 because this is usually at about 24 hours of age, okay? Note the color. This is why they don't get a 10, is because babies aren't pink right away, okay? So when that cord is cut, the heart starts pumping blood to vital organs first, such as the stomach, the lungs, the liver, everything that's vital. And those hands and feet are not the most vital organs, okay? They're going to be blue for a while, and that's called acrocyanosis, and we'll talk about that later. This is what your baby's gonna look like at birth, okay? This yellow is vernix, and this is a protective coating for the baby to prevent it from wrinkling while in the amniotic fluid. Ever been in the pool too long or the bathtub too long and your hands are pruned? That's what your baby would look like without this vernix, okay? So it's like a white cream cheese-like substance. It's a very good moisturizer for the baby, and when we dry them off, we try to rub that into their skin. So the molding of the head. So as that baby is coming down the pelvis, the head's gonna mold, and they have sutures in their head, and they're made to mold so that they can fit through the pelvis. In a couple days, it's gonna go away to a nice round little head. We keep a hat on the baby because they don't know how to regulate the temperature for the first few days. So unless somebody's gonna take the baby's hat off, they're not gonna really notice that they have what's called a cone head or molding, okay? Milia, that is like pimples on your baby's nose. They are clogged pores that will eventually go away. Don't pick or squeeze them because that's just opening an avenue for an infection to be able to get in. Okay, so just kind of let them be. You can wipe off their face in the bath with a warm washcloth, but please do not pick or squeeze at them. Babies also have soft hair all over their body, and that also helps protect their skin while they're in the uterus, which is obviously full of amniotic fluid, so it's wet. If you have a premature infant, they're going to have more lanugo or hair than a full-term baby. The eyes. So all babies tend to have bluish gray color. You will not know their true color for up to 9 months. They can see up to 12 inches at birth, but they will generally keep their eyes closed because it's super bright and they've been living in utero and it's darker in there. If you try shading their eyes with your hand, they usually tend to open them for you. Boys are going to have very swollen scrotums, and this is due to the pressure that is placed on them as they come down the birth canal. And little girls will have swollen labias and lots of mucousy discharge. And this is just due to the hormones that are passed from the mom to the baby. On the 5th day of life, they could have a little bit of blood-tinged mucus, and that's totally normal. Again, it's just from the hormones that are passed from mom to baby during delivery. So the skin, the babies can have what's called like a stork bite, and it literally looks like a beak bite, like that a stork bit them, and it's usually either on the forehead, the chin, or in the back of the neck. They're not birthmarks, they're gonna fade with time. The baby's hands and feet may remain bluish in color for up to 24 hours, hence why they don't usually get a 2 for color on their APGAR, and it's called acrocyanosis, okay? The umbilical cord will be clamped and cut close to the baby's body after delivery. So during a vaginal delivery, we give dads a chance to cut the cord. During a C-section, the providers cut the cord. They leave it a little bit longer. They'll allow dads or support people to cut the cord over at the NICU warmer after the NICU gets done evaluating. The stump's going to dry up and fall off on its own about 10 to 21 days. Usually you'll find it in the diaper or in the onesie when you go to change the diaper, okay? So gonorrhea back in the 20th century was it was a problem in causing blindness for babies. So being that sometimes we don't always see an infection in the birth canal because they can lie dormant within for like 7 to 14 days, we give every baby what's called erythromycin ointment. It is an ointment in their eyes, and it protects against gonorrhea or any other infections. So we put it right inside their eyelid. At first, it's kind of like gooey, but we just ask you don't touch it. It'll evaporate. It'll go away, okay? Their eyes can become inflamed or swollen from this treatment, but it'll go away in a day or so. Also, babies get 12 days of vitamin K from the placenta, but we like to give them a jump start just in case anything were to happen. So vitamin K helps with blood coagulation. So it helps if there's any like bumps or bruises or anything. It helps to clot that blood off so the baby doesn't bleed. We will be giving the injection in the baby's thigh, and it's usually given after that 1 hour of skin to skin. Usually around when we do the weights. Again, identification of the newborn. So the baby's going to have a wristband on their wrist and on their ankle. It will match mom and dad's. So mom and dads or support people get a matching bracelet. And again, that's the only person that can be in the hallway with the baby or can pick the baby up from the nursery if need be. We're going to take all of your baby's vital signs to make sure baby's healthy, and then the baby's healthcare provider will come and do the initial exam. One thing I do want to mention is our footprinting now is all done electronically. So we scan the baby's footprints into the computer and it's all done electronically. If you do have like a baby book or something, you may bring it. Sometimes we are able to do the stamping, but it just kind of depends on the needs at that time. The RH factor. So RH is a term for what makes blood positive or negative. When an RH negative mom has an RH positive baby, the baby can be born anemic or with lower than normal levels of red blood cells. So all RH negative moms, unless the baby's father is also RH negative, they're going to receive an injection of RhoGAM at 28 weeks of pregnancy. And this is because the baby's blood type is unknown and it's going to be assumed to be RH positive, okay? The injection is going to help prevent anemia in the newborn. The metabolic screening. So this is essential and preventative health measure. It tests for developmental, genetic, and metabolic disorders in the newborn that we're unable to see with a naked eye. Okay, this is a blood test. They take the blood from the heel, they put it on the pieces of paper, and then they will send it downstate. Okay. Every 1,000 babies born, it's estimated that 1 to 3 will have serious hearing loss. So we do the hearing screening here. It's becoming common practice. The pulse oximetry screening for congenital heart disease, we just hook it up to your baby's to the right hand, and then we get a reading before we send you home in order to kind of detect for congenital heart disease. So general care for baby, your baby's going to be scheduled for regular well baby visits and exams to monitor growth and development. This is a good time for you to learn how to handle problems such as crying, fever, vomiting, diarrhea, any feeding problems that you're having. And these visits are most frequently done in connection with your immunization schedules. I will show you an immunization chart in a minute, and that is just kind of like a guideline, okay? So when you're going to go and meet with your pediatrician as in before, just kind of make sure you guys are on the same page about immunizations and if you're okay with having them have the immunizations at the time that your pediatrician recommends. So again, we're going to talk about the average newborn weighs about 7.5 pounds at birth. They're going to lose 5 to 8% of their birth weight in those first few days of life, and then they're going to start to gain again. So when they start to gain, they're going to regain their birth weight by day 10, double it by 6 months, and triple it by a year. Skincare, so again, like the milia that we were talking about, they often have skin blemishes and rashes. They're totally harmless. It's just like newborn acne. Again, don't pick at it, don't open it up, just kind of let it be, okay? You can just wash with soap and water. So for the sponge bath for the baby, so you can do, this is like our bathtub that we have here. When you're gonna wash the baby, you're gonna wanna make sure that you have like a changing mat, a baby bath towel. I don't say cotton balls because I hate the little hairs that it gives off. So just washcloths for the baby, a few of them. Baby shampoo, diapers, and clean clothes. So the first tub bath, our pediatricians recommend not to submerge them in a tub until after their cord falls off, okay? So before that, you're just kind of going to use washcloth and kind of just wipe them down, okay? So don't submerge them until the cord falls off. So when you bathe the baby, you're going to wash from the inner aspect of the eye to the outer. You never want to go from out to in. You always want to go from in to out. You're going to wash the face with clean water, wash behind the nose and in the ears. Make sure you get every fold and crevice. When you have those chunky babies, make sure you're getting into every fold and crevice, especially in the neck, okay? When they're breastfeeding, it's going to leak down their neck, or when they get sweaty, it's in their neck. So a lot of times when you lift up their neck, you're going to have like a white chunky substance or just dirt, and that's why we tell you to get in every fold and crevice, okay? Check the umbilical cord for proper healing. Make sure you're using clean water on the genitals when you're cleaning the genitals. And the bath time is a wonderful time for you and your baby to learn touch. So here's a picture of an uncircumcised penis and a circumcised penis. And the American Academy of Pediatrics policy states that a circumcision has health benefits, and parents should actively discuss this with their healthcare provider when making the decision. Just know if it doesn't happen at the hospital, if you choose not to get the circumcision at the hospital, but if you choose to do it later, it's not just an appointment with the pediatrician. You have to go through urology, and there's a bunch of different steps to be done, okay? Jaundice. So jaundice just means the baby is yellow. It causes a yellow appearance to the baby's skin and their eyes, and it's from a normal body chemical called bilirubin. If you see yellow skin or eyes, you need to call your newborn immediately. But when your baby is breastfed, so the breast milk and the bilirubin attach. So the bilirubin actually, the excess of it will come out via the urinary tract or the meconium, but it attaches to the breast milk. So that's also a good way to help decrease jaundice is by breastfeeding.
Babies communicate many different ways. They use different cues such as facial expressions, noises, and body movements. One cue that parents may find hard to help their baby with is crying. If you watch your baby's cues, you can sometimes help her before she starts crying. Crying often increases at 2 weeks of age and may peak at 6 to 8 weeks. It is normal for infants to cry more at 2 months than as newborns. Sometimes babies cry often for a long time. Babies cry for many reasons and sometimes for no reason at all. At times they can't stop crying no matter what you do. Feeling frustrated and overwhelmed is absolutely normal. There are many ways to comfort a crying baby. After checking to see if your baby is hungry, needs a diaper change, or is sick, you may find it helpful to rock her gently, snuggle her close, play soft music, go for a walk, give her a warm bath, or take her for a car ride. Each baby has different needs, and it will take time to get to know your baby. Never shake your baby. Shaking your baby can cause brain damage and even death. When you feel frustrated with your baby's crying, put her in a safe place and walk away for a minute. Take a deep breath and count to 50. Do what you need to help you relax. It is okay to ask for help from friends and family that you trust. Sometimes a grandparent, child care worker, or a babysitter will be watching your baby. Anyone who cares for your baby should understand normal crying, how to comfort a crying baby, and when to ask for help.
Okay. So keeping your baby safe at home, you're never going to want to leave a baby, even when they're sleeping, alone on a bed, a table, or surface where they could fall. You want to install gates at the stairwells. Any small object can be posed as a threat, so you always want to make sure you have those up and out of reach. Plastic garbage bags, keep those out of reach. Check the airflow and the temperature in the baby's room. A baby's sleeping area should be free of strings on sleepwear, bedding, and a pacifier. So we do have these sleep sacks that we do hand out here. So what it is we just recommend you put a onesie on the baby. You're going to put the baby in the sleep sack, and then in order to sleep, you can swaddle them. So this is a really nice swaddler that has Velcro, okay? So you can swaddle them up and keep their arms down. So this is something that it's free of strings, it's free of everything like that. So keep anything sharp that can be kept in the childproof containers, remove them. Make sure all of your wall sockets around your home have the plugs in them. Safety locks should be installed on all doors to the pool area. Keep your guns locked, unloaded, out of reach. Double check the temperature of the baby's bath water to make sure it's not too hot. This area on your wrist is the most sensitive part of your body, so always use that to check it. Don't hold your baby while you're cooking, because they could kick or grab or anything, the pot of water or whatever you're cooking, and that's going to be hot and could burn them. Anchor any furniture to the wall. Avoid direct sun exposure during the first 3 months of life, and don't allow anyone to smoke around your baby. Car safety. Never leave a baby in a car unattended, not even for a moment. Don't put a rear-facing seat in the front seat of anything where the airbag is present. The baby should have a safety car seat for the very first ride home from the hospital. And an infant's car restraint should have the words dynamically or crash tested on it. If you are getting a hand-me-down car seat, please be sure to check the expiration date and make sure it's never been in a crash. You're always going to want to keep the car window closed and the door locked nearest to the baby. And the American Academy of Pediatrics recommends that the children should ride in a rear-facing seat as long as possible. It is now the law that they have to be rear-facing until the age of 2. So keeping your baby safe. Remember, no matter how tired, angry, frustrated you get, never shake your baby or toss them into the air. So this is the baby that we use to explain that. So if you shake your baby, you can see the brain rattles around in there. Okay, tossing your baby in the air, it kind of shakes the brain as well. So never shake them or toss them in the air. Always protect your baby's head from any jerking movements, okay? So warning signs that you want to call the doctor. Blue lip color or pale or blue skin around the mouth is a 911 call. Yellow skin or eyes could indicate jaundice. Any white patches in their mouth could indicate a yeast infection, and that's just due from feeding. Eating poorly or refusing to eat, no stool for 48 hours, less than 6 wet diapers a day. If there's any redness, drainage, or foul odor from the umbilical cord, we want to know. A fever greater than 100.4, any difficulty breathing, repeated vomiting, listlessness, crying, or frequent bowel movements with excess fluid, mucus, or an unusually foul odor, very strong odor. Immunization, so their baby's going to get all these immunizations. Like I said before, it's a matter of your pediatrician's recommendations as far as the schedule. So kids can get influenza shot after 6 months of age. It just comes in 2 shots, okay? But like I said, these are all the immunizations that we recommend. The schedule will depend on the pediatrician. So the Center for Disease Control recommends that all pregnant women receive the Tdap vaccine during the 3rd trimester or late 2nd trimester. Mothers are the primary source for the infant getting pertussis. So what could be a small cold to us or a cough could be pertussis to infants. So by getting vaccinated during pregnancy, the antibodies are transferred to the newborn, likely affording protection against the pertussis. So any family members or caregivers of the infant need to get this vaccine at least 2 weeks before coming into contact with the infant. If you did not get the Tdap before you delivered, we recommend an immediate postpartum period, including those who are breastfeeding. Here's just a copy of the immunization schedule. Like I said, it could change, it could vary, but this is what we recommend. So sudden infant death syndrome is a sudden infant of a death under 1 year of age which remains unexplained. One of the best ways to reduce the risk of SIDS is to place the babies on their back alone in their crib, so ABCs. Since the American Academy of Pediatrics recommends babies be placed on their back to sleep since 1992, the death from SIDS has declined dramatically. So sleep-related deaths, including suffocation, entrapment, and asphyxia, have increased. So they recommend, again, alone on their backs in their crib. So even in their crib, you're not going to want to put any like bumper pads or any stuffed animals or any extra blankets. We recommend simply just a sleep sack alone on their back in the crib. Always put your baby on their back for sleep time, nighttime, and nap time. Use a firm surface. The baby should sleep in the same room as the parents, but not in the same bed. Keep soft objects and loose bedding out of the crib. Any devices to maintain a sleep position are not recommended. So they have not been tested successfully for any safety. Do not smoke during your pregnancy, after birth, and do not allow others to smoke around your infant. Breastfeeding has been associated with the reduced risk of SIDS. Consider using a pacifier at nap time or at bedtime, but don't have it clipped to the baby. You can just set it in the crib for the baby, but don't have it clipped to them. Keep your baby's head and face uncovered during sleep. Don't let your baby become overheated. The recommendation is you just put your baby in one more layer than you're in. If you're sleeping in t-shirt and shorts, put your baby in a long sleeve onesie and this, okay? Keep schedule and go to all your well baby visits, and supervise awake tummy time is recommended daily to help with the head control and muscle development and minimize the occurrence of your baby's head becoming flat. So just a simple tummy time, have the baby on the belly. I can guarantee you they're not going to like it at first, but keep doing it. And, you know, even getting down on the floor and do eye-to-eye contact with them will help alleviate the crying. So shaken baby syndrome and abusive head trauma, again, never shake your baby. Shaken baby syndrome is when the baby is shaken forcefully, which causes brain damage and or death. If you or anyone shakes your baby, please be sure to seek medical attention immediately. Do not let fear, shame, embarrassment, or guilt or anything get in the way of this. Getting the necessary and proper treatment without delay may save your child's life. Enjoy your journey. Each baby is unique. Please know that parenting is a process that requires you to constantly learn, and you're going to discover new skills that are going to help you. So we are also going to do go over a couple more things like frequently asked questions.
We are also going to go over things too that weren't in the video, okay? So a couple things real quick. We want to go over the peanut ball that we use here at the hospital.
So we use this, and this goes in between your legs. So it sits right in between your knees while you're laboring. It can be used with an epidural or without an epidural. And what it does is it opens your pelvis and it opens that birth canal to allow the baby to come down into the birth canal. So it actually aids with labor. A lot of moms who use it that don't have an epidural say that it takes the weight off of the hips. So a lot of you, I'm sure, are sleeping with a pillow between your legs right now for comfort. This is also another way to help that.
There are also 3 different sizes. It depends on how tall you are. This is the one for like the average height for women. I think it's 5'2" to 5'7". So this, again, goes between your legs. It really does open up your hips, and it just helps kind of bring that baby down in that pelvis, okay? So that is our peanut ball we use.
The next thing, as we talked about monitoring and we talked about flipping you from side to side and to aid in baby's position. Also, these babies run the show. So some babies aren't exactly happy with what we're going to be doing, whether it be Pitocin, Cervidil, Cytotec, whatever we're doing to try to get labor going. Or some babies aren't even happy with labor itself. So we can use what's called a non-rebreather mask and flip you on your side, give you some extra fluids, but this just simply is placed right here and it gives you extra oxygen in order to oxygenate the baby through the placenta, okay? So this can be used if we just baby needs a little bit more oxygen, or if we're trying to have baby wake up a little bit during labor, okay?
So if you see a bunch of us come in, we kind of all work together. You may not even know what's going on. One person may be increasing your IV fluids, the other nurse may be turning you to a different side. You may have another nurse coming in and putting this oxygen on you. We all work very fast and work as a team, so you may not know anything's going on. We work very quickly, and then we will kind of update you as we go. What we're mainly trying to do is get baby to start cooperating and behave itself, okay?
For another thing for the baby, so this is to suction secretions out of the mouth and the nose. You always want to start with the mouth first and then go to the nose. When you do the mouth, the reason why you do the mouth first is because if you do the nose, the baby's going to automatically suck in, and any secretions that are in the mouth are going to go down into the lungs. So we want to clear that mouth out first and then go to the nose.
You'll see that also used kind of right after delivery. The doctor will use it, kind of get that amniotic fluid, clear their mouth, clear their nose. A lot of people will use it too if the babies get spitty, gaggy, or choky. If you do kind of notice that, you can always call your nurse for help. But you want to kind of lay them on their side or sit them up, put it inside their cheek area, not straight back. Have it sucked in, and then you're going to suck everything out and then spit it out on like a burp cloth or something, okay? Next thing we are going to talk about is after you deliver, you're going to have bleeding, okay? You will bleed for about 3 to 6 weeks after delivery. The first few days will kind of be like a heavy period, okay? We want to know if you have any really big gushes of blood or if you're passing any clots, okay? You will wear a pad, okay? So these are what these look like, and we will give you our fishnet underwear, all right? So this is the pad that you will wear usually the first couple days, all right? It kind of soaks up that blood. If you are saturating one of those in less than an hour, you need to let us know, because that means you could be bleeding too much, okay? And we want to kind of monitor that. If you have stitches or you're pretty swollen, this is an ice pack that we will put on top of that pad, okay? This is a pad, but it doesn't really hold a lot of the blood. So that's why we put this on top of the big pad to kind of catch the excess bleeding that is going on. So use this for the first 24 hours. Will help with pain relief if you have any stitches down there, or if you have any cuts that weren't that had to be stitched up, but this also will help with swelling, okay? So this goes on in here, and you put it on, all right? I know it's pretty big and bulky, but eventually you'll be able to go to regular maxi pads, okay? The first 6 weeks, you do not want to use any tampons, no douching, nothing in the vagina for 6 weeks. Your postpartum visit, your OB will schedule with you. It's usually 4 to 6 weeks after delivery. So nothing in the vagina for that long, okay? If you have a C-section, you will have usually sutures, so those are stitches that are dissolvable. Sometimes they'll put glue on it, and sometimes they'll do staples. So whatever that incision choice is for your provider, they will go over when they want you to follow up for an incision check. Usually it's about a week after you deliver, okay? With a C-section, you're not able to drive for 2 weeks after delivery, okay? So you need to have somebody take you to your appointment, be able to pick you up, run errands if you need stuff at home. Vaginal deliveries, it's usually a week after delivery, no driving, okay?
Once after you deliver vaginally, after that 2-hour mark, we get you up and go to the bathroom and kind of clean you up. Even if you don't have stitches down below, you are going to be sore. So we don't recommend wiping with toilet paper. We're going to have you fill up this nice little Perry bottle with warm water, and you can rinse off, and then we just have you pat dry with the toilet paper. And then that's when we're going to give you this nice little mesh panty setup that we have here. One thing I do want to add about this, the ice pack, is that if you feel like you're leaking, remember this is an ice pack, so it's probably like the ice melting. And we're happy to get you more of these, okay? We also do have what's called Dermaplast. It's like a numbing spray that you can spray down below also to give you some relief, okay?
All right, so frequently asked questions. We'll kind of go over some of those since we don't have any audience really here. So we'll kind of go over some of those. Like some of the major ones are, will my husband pass out during the epidural? Hopefully not. We are pretty good about that. We've had people pass out. They won't be the first one. They won't be the last one. We try to minimize that. So if they get kind of squeamish with that kind of stuff, they can either step out. Your nurse can be your support person for that period of time during the epidural. Or if they think they'll be okay, we can always take a chair and stick it right behind them. So if they do kind of start to feel yucky or something, they can just sit down and they don't fall, okay? We have had patients that their spouses have fallen and they've needed to go to the ER to get, checked out and evaluated, and we don't want that to happen during your birth experience. Especially during delivery as well, sometimes they get a little squeamish. If they do that and they think they might, same thing, we'll put a chair right behind them so they can sit down and still be supportive and be there for you, okay? So that's one of the main questions we get as well. Will I see the epidural needle? Is it really long? No, you won't see the epidural needle. We don't just go out and show you what it looks like. So what they'll do, anesthesia will come in and talk to you, you'll sit with us, and then they prep everything behind you, and then they start the process. So you will not see the epidural needle, okay? Another frequently asked question that we get a lot, people are scared to ask this, is will I have a bowel movement when I'm pushing, okay? I would say probably about 50% of people do, all right? It's normal. We're very quick. Your nurses, your providers are very quick about keeping you nice and clean down there. So you probably won't even know that you do have one if you do, or your support person won't know as well, okay? It doesn't happen all the time. It doesn't mean you're going to, but it also doesn't mean that it couldn't happen. So just be aware that that is something that generally can, okay?
And we do want you to use those muscles that you're going to use to have a bowel movement when you're pushing. So we want you to not worry about that at all. When you're using those muscles, and if we do see a bowel movement, that just means that you're using the correct muscles in order to push. So that is actually a good sign.
Yes. Other things too, so if you are out in the halls, make sure your baby is in the bassinet. You can't walk around the halls holding your baby. It's a safety hazard. If they're, cleaning the floors or anything like that, we don't want you to slip and fall. So if you are outside of your room with the baby needs to be in the bassinet. If you are in your room, you are able to walk around with your baby freely, okay?
Another thing, and to aid the support people or fathers of the baby, as much as you want to argue about this, a lot of people do, keep your bellies full. I don't care if mom can't eat, if you want to support her, but the biggest thing in order to help you not pass out or not fall down or whatever during the epidural or birth, keep your bellies full. Make sure you're eating and drinking, and that's going to help you, okay? And if you have any further questions that we haven't been able to answer here, we recommend that you contact your OB providers or contact your hospital that you're going to be delivering at. Okay, and they'd be happy to answer it for you.
All right, thank you so much. We hope you enjoyed this.